Harry, and thank you, Jonathan, for inviting me. This is actually a little bit different venue from those I usually give talks in. I spend most of my time, about 90% of my time, running a lab, but also allow me to make completely new slides and think about the problem a little bit. So this is going to be the first talk talking about metastatic disease, and whenever I talk about metastatic disease, I have to go back to Dr. Charles Huggins, who published a seminal study 75 years ago when he showed that in patients with symptomatic metastatic prostate cancer, that castration or oral estrogen causes regression in essentially every patient and symptomatic improvement. So this really highlights a number of things that's very specific for prostate cancer, as all of you know. It highlights the importance of lineage in prostate cancer and lineage-directed treatment. This is the first systemic treatment in any cancer. It's the first drug, in fact, estrogen is the first oral drug that was used to be effective in any cancer. And I think of it, even though people think of imatinib as a dawn of targeted therapy, I think of this as a dawn of targeted therapy. So Dr. Huggins won the Nobel Prize in 1966. And I just quote here from his Nobel Prize lecture that he said, the first series of patients with prostatic cancer treated with orchiectomy comprised of 21 patients with far advanced metastases. Only 4 of them survived more than 12 years. Despite regression of great magnitude, it's obvious that there are many failures of endocrine therapy to control the disease, but on a whole, the lifespan has been extended by the novel treatments, and there has been decreased man-paying years. So I want to focus here a little bit on this 4 out of 21 in 12 years. And this highlights another thing. The last session we were talking a lot about patients who are metastatic, and we said that they are not curable, but in fact, in a substantial minority of patients, you can have very long-term responses to androgen deprivation therapy alone. But on the other hand, as prostate cancer is a very heterogeneous disease, and many people, in fact, progress very rapidly. So this is a contemporary series. This is Kaplan-Meier from the STAMPEDE trial. You may know the trial. This is the patients that were on the control arm. So this is how long it takes a contemporary patient with metastatic disease to develop castration resistance here and die of the disease here. As you can see, there's actually a couple of points to make. One is that the median progression-free survival is actually less than a year. So it's probably shorter than you may think. But there's a long tail that goes out 5 or more years of approximately 15% of patients. And in fact, on the other hand, full 25-30% of patients progress in 6 months or less. So really, some of the questions that at least to me, I want to frame when I see individual patients are, who are these patients out here where, despite having metastatic disease, they only need androgen deprivation therapy. And in fact, one of the questions is somewhere out there, is it even okay to withdraw androgen deprivation therapy? Can they be cured? We don't know that. And how can we do better in patients here? And this type of Kaplan-Meier curve is in fact similar to every stage of the disease. So as we get to castration-resistant prostate cancer and looking at every treatment, there are some that respond for a very long time, especially for the second-generation anti-androgens, and there are some that progress immediately. So I think treating patients is always very humbling, and I just want to highlight this in a couple of patients that I treated. So this is actually one of the first patients I saw when I became attending here. And this was in 2011, November 2011. I saw this gentleman who was 72 years old. And he presented with urinary obstruction. And he came in on a Foley. And what he had was he had a very, very large primary prostate cancer. He had lymph node metastasis. He had bone metastasis. And he had 2 liver metastases here that were biopsy proven to be prostate cancer. His PSA at this time was only 3.3. So knowing everything that we know, we will assume that this person will not respond well to androgen deprivation therapy by itself. And in fact, if I knew then what I know now, I would not give this patient only androgen deprivation therapy. I would at least combine it with something else, probably chemotherapy. However, this was 7 years ago. and he only got androgen deprivation therapy. And this is his most recent scan. His PSA nadir. In fact, I just forgot to mention, he did have a Gleason 5+5. I actually talked to Anu on the phone who told me this is one of the very rare patients that she sees that has Gleason 5+5. But this is 6 years later, his scan's completely clean, and his PSA is undetectable. So in fact, this another thing that highlights it for me in a patient like this is, we could have treated him incredibly aggressively. We could have, ablated the liver lesions, radiated all the lesions, given him chemotherapy and ABI, and then he could have, had a very long-term survival. And we certainly would have patted ourselves on the back and said that's because of all the aggressive treatments that we did for him. So it's very humbling. So patient number 2. Is somebody that I saw much more recently for the first time. He came in, he's a 61-year-old, came in with a PSA of 20. And he came in with bone-only metastasis. He had a prostate biopsy. He had only 3 out of 12 cores that were positive. And 2 of the 3 cores were Gleason 3+3, and 1 of the 3 positive cores was Gleason 3+4. Now, due to this bone metastasis, and he had several of them, he actually did get, I decided to give him ADT plus docetaxel up front. And then when he progressed on enzalutamide, within 6 months, essentially he didn't respond to anything that was given to him. And he's greatly debilitated from the disease. This obviously gives us a number of questions to ask. And over the past 13 years, we, in fact, have now developed a number of therapies. I think Dana and Howard go through these in detail, but we've developed a number of chemotherapies and targeted therapies for metastatic, either castration-resistant metastatic prostate cancer, or therapies that's given upfront that's been shown to improve survival. And the question is, what are the when to use these and which ones are optimally used. So here's the questions I will pose. And instead of a broad general question, this is a question that every one of us asks when we see a newly diagnosed patient. So in the setting of hormone-sensitive metastatic disease, who will, as I've said before, who will respond indefinitely to ADT alone, and who will derive the most benefit from docetaxel, abiraterone, or other agents, and who will benefit from aggressive local and focal therapy. In patients with castration-resistant metastatic disease, how do we start? Do we use AR-directed therapy? Do we use chemotherapy? And who will benefit from the novel targeted agents, many of which are approved, but not necessarily for prostate cancer? What are the biomarkers, and how do we obtain these biomarkers? Now, I'm not going to really try to answer these questions. I hope some of the talks after me will help to answer that. But first, I'm going to address a couple of questions and just perhaps give a couple of caveats. So how do we address whether to use chemotherapy or further androgen-directed therapy? So I want to step back a little bit, and this is something that I think all pathologists know and all of us know in the lab, and that's the normal prostate gland is in fact made of several sublineages. And the sublineages include basal cells that support the luminal cells, neuroendocrine cells, and luminal cells are the functional unit of prostate that makes the seminal fluids that is AR positive, and that make PSA. So in the normal prostate, in fact, only the luminal cells are androgen dependent, and they have markers of luminal cell, including AR. As many of you know, prostate cancer is not just a cancer of the prostate lineage, it's a cancer of the prostate luminal lineage. And one of the pathologic diagnoses of cancer versus normal glands is loss of basal markers, such as CK5 shown here. As you can see here on the left, you have cancer that stains positive for the oncoprotein ERG. On the right, you have benign glands that still are positive for the basal marker. So if you look at primary, one of the questions that we want to ask is, if we compare primary prostate cancer versus CRPC adenocarcinoma versus neuroendocrine carcinoma, what happens to their lineage, because androgen-directed therapy is targeting the luminal lineage. What happens to their luminalness? And you can look at a number of things. I just choose to show you one of these markers here, which is AR itself, the target of androgen-directed therapy. And this is data from the Cornell data set. And here it just shows the expression level on a log scale of AR. What you see is in that primary prostate cancer, AR is pretty homogeneous. But upon CRPC, a great percentage of prostate cancer, you have very high upregulation of AR, which has been known now for years, and which is the basis for development of enzalutamide and abiraterone. But you also have some that completely lose AR, and if you have neuroendocrine prostate cancer, you completely lose AR. So one of the predictions here is that if you were in a lineage where you may stay luminal and you're locked in the luminal lineage, you will respond to further AR-directed therapies. At least you have a possibility of responding to further AR-directed therapies. Whereas if you go into an AR-negative lineage, then chemotherapy or other therapies patient would be better served. So this is one framework that at least that we can think about as we think about individual patients. In CRPC, a number of cancer remain luminal locked, this is what I call it. So they remain AR positive, they remain dependent on AR signaling. And they may or may not respond necessarily to AR-directed therapies. They harbor AR amplification mutation, as I've shown you. Some of them may, the AR mutations may respond to mineralocorticoids or progesterone, and this may predict for resistance to abiraterone sensitivity to enzalutamide. Some of them may have specific AR mutations activated by enzalutamide that may predict to sensitivity to abiraterone. And there may be AR splice variants, as Mike has talked about, where they're still luminal locked, but they are resistant. And there's some data that glucocorticoid receptor and other AR-like receptors can function as AR. And these would still be in this luminal lineage, but they will be resistant. On the other hand, about 20% of CRPC will gain lineage plasticity. They may or may not necessarily become neuroendocrine cancer. They may or may not necessarily become AR negative. But functionally, they become AR independent. They grow faster. They have increased tumor heterogeneity. And because of their more rapid growth, they may possibly have increased sensitivity to chemotherapy, especially platinum-based chemotherapy. So how do we try to put patients into individual buckets? And this has been mentioned by Phil and a number of other people, but I just want to mention it here. Here at MSKCC, we have developed a sequencing, tumor sequencing and germline sequencing pipeline called MSK Impact that sequences approximately 500 tumor-related genes as well as germline genes associated with tumor predisposition. It's important to note that this type of sequencing right now is not approved for prostate cancer. However, we've done almost 1,000 of it in prostate cancer, so there's definitely a lot of a great group effort from everybody in order to do this. And this is exactly what Phil has shown, which is data that was presented by Ysema Beta for the first 500 patients with local regional disease, non-castrate metastatic disease, and CRPC. And what I've highlighted here is genes whose frequency are increased in CRPC compared to local regional and compared to non-castrate metastatic disease. As you can see, there's a great increased percentage of patients with AR amplification or AR mutation. But the other is loss of these tumor suppressor genes, P10, P53, RB, and Phil has gone into great depths about BRCA2. So in particular, if you look at the subgroup of patients that don't harbor AR mutations and amplifications, there is a significantly greater percentage that they may have both harbor a combination of P53 loss and RB loss. So why are we interested in this combination of tumor suppressor loss? One of it is that the combination of P53 loss and RB loss essentially defines neuroendocrine, aggressive neuroendocrine cancers, including small cell lung cancer. You can see 100% of small cell lung cancer has this combination. and also other aggressive neuroendocrine cancers such as Merkel cell of the skin also 100% have this combination. So, so Charles Sawyer's, before I get to that, so this was also looked at in an MD Anderson study performed by Anna Aparicio, where they looked at immunostaining for RB in a number of tumor samples and correlated it with AR staining as well as tumor growth rate by Ki-67. And as you can see, loss of RB is correlated with loss of AR, although not completely, and also a significant increase in tumor growth rate. So this has been studied in the laboratory, in Charles Sawyer's laboratory. And here, I just want to show you one slide where he looks at time point of getting rid of RB in a prostate cancer cell. And what you see here is that when RB is lost, you see increased expression of other lineage markers here of both basal cells, which is CK5, CK14, and P63, and also of neuroendocrine cells, which is synaptophytes and chronogranina and neurospecific enolase. And this is also correlated with resistance to enzalutamide in vitro here, where these cells are sensitive, and if you put in these two genes, they become resistant and they grow as fast as if there were no enzalutamide. So I just want to also show you some additional work that we've done in our lab, and that neuroendocrine and squamous, or basal cell and sometimes squamous cell, are not the only two ways in which prostate cancers can differentiate or transdifferentiate. Before going to that, I just want to show you a recent patient of mine that in some ways, in my mind, pretty definitively implicates the loss of RB in this transdifferentiation from adenocarcinoma into neuroendocrine cancer. And this is a patient that presented with metastatic cancer, PSA about 100. And he had biopsies on the left side as well as the right side. The right side showed neuroendocrine carcinoma, and the left side showed typical adenocarcinoma. And we're lucky here that we can do sequencing on both. And on adenocarcinoma, you can see that it has a P53 mutation, PTEN loss, in fact, a beta-catenin mutation. But whenever you see these, you're asking, is this a collision tumor? Is it two different tumors? Or is it the same tumor that has just gained another mutation? And in fact, the small cell histology has everything up here and an RB intragenic deletion. So as I was mentioning, work from our lab has shown that a small percentage of primary prostate cancers, but up to about 30% of castrate-resistant prostate cancers now transdifferentiate into GI lineage. Now, they're still adenocarcinoma, so you can't really differentiate them simply by looking at HI-E stains. But if you were to stain them for things like albumin or other stains, you would see that they will light up with GI lineage genes. And this is mediated by a transcription factor called HNF4G, which is like AR. It's a ligand-driven transcription factor, and it's potentially druggable. And in the laboratory, when we put HNF4G in a graft, they become more rapidly resistant to enzalutamide compared to control. And when the grafts become resistant, the resistant grafts compared to untreated grafts now express more of this master-regulated transcription factor, HNF4G. So finally, I'm going to finish the talk by addressing this last part. What about other agents? Who to select for novel targeted agents? What are the biomarkers? How to obtain biomarkers? I'm just going to give two caveats since I'm running a little short on time. So now if you look at the data that was generated by MSK Impact, Phil has given you a significant amount of data showing that that defects in homologous recombination DNA repair predicts for sensitivity to PARP inhibitors and platinums, and also resistance to androgen deprivation therapy. I'm going to show you some data that with mismatch repair, which Phil has also mentioned. So about 4 or 5% of prostate cancers have mismatch repair and a large number of mutations. And also I'll show you some data with AKT, which is mutated in a very small percentage of prostate cancers, but we may have a drug that could benefit this subset of patients. So mismatch repair is important Why is it? It sporadically occurs in a lot of different cancers, including prostate cancer. And when this was given to patients with mismatch repair, in all different cancers, they all respond to checkpoint blockade. And if you look at the progression-free survival and overall survival, this is very significant. And this is something you do not want to miss in your patient with CRPC, even if it's very rare. And also very importantly, this treatment is FDA approved if you can prove that your patient has mismatch repair. And the last slide I'm going to show you and this is truly targeted therapy. This is of patients with this AKT mutations, and they were given this AKT inhibitor called AZD5363. And this is of patients with all different cancers, including prostate cancers here. And there was an excellent response rate in the 3 patients that had prostate cancer. So I'm going to finish up here, and just the take-home points is response to therapy is highly individual at every stage of disease. I just want to highlight here that lineage plasticity is a determinant response to AR-directed therapy. And tumor and germline sequencing can unveil therapeutic biomarkers, including some of which is outlined here: resistance to AR-directed therapy with RB loss or BRCA2 loss, as Phil had mentioned, sensitivity to platinums or PARP inhibitors with BRCA or ATM loss, sensitivity to immunotherapy with mismatch repair defects, and sensitivity-specific kinase inhibitor. I'll show you the example of AKT. There's ongoing work looking at PTEN, PI3 kinase, RAF fusions that is still preliminary, but you may hear more about in the near future. All right, thank you very much.